In 2007, the Institute of Medicine published the report, Cancer Care for the Whole Patient. In this report, the convincing evidence that psychosocial care improves patient outcomes was presented. The report also recommended that the provision of psychosocial services be adopted as a quality care standard. Over the next 2 days, we focus on this quality care standard. Indeed, this is our conference theme, implementing quality care standards in psychosocial oncology and supportive care. Our session this morning focuses on the inclusion of psychosocial distress screening among the quality care standards that the American College of Surgeons Commission on Cancer requires for accreditation. This morning, Tampa Bay Times staff health writer Irene Maher will interview Stewart Fleishman and Lynne Wagner about this standard. I am deeply grateful to Irene, who in very short notice has stepped in for the New York Times columnist Teresa Brown, who alas could not make it. Thank you very much, Irene.
My pleasure. Great to be here.
Before he went to medical school, Stewart Fleishman taught in the New York public schools, and after medical school, he had a fellowship in psycho-oncology at Memorial Sloan Kettering. Then he founded cancer support services at Mount Sinai Continuum Cancer Centers of New York and served as the Associate Chief Medical Officer of Continuum Hospice Care. He's the author of 2 books, and he was the APOS representative to the American College of Surgeons Commission on Cancer, for whom he currently surveys cancer centers around the country. I also learned that he speaks Spanish. Bienvenidos. Dr. Lynne Wagner is a clinical psychologist, an associate professor, and director of translational research program in the Cancer Survivorship Institute at the Lurie Cancer Center at Northwestern University. She leads a program of cancer control, survivorship, and quality of life research within the NCI-funded National Clinical Trials Network. She currently serves as the APOS representative on the American College of Surgeons Commission on Cancer. And this morning we're going to learn how and why they got the Commission on Cancer to adopt psychosocial distress screening as a quality care standard. Thank you, Irene. Over to you.
All right. And my editor would be very upset with me if I didn't show you. This is my newspaper. It's the Tampa Bay Times. So please buy it often, read it often, and thank you very much. That's the end of my commercial. Now, I'm going to lay this out as I understand it. You feel free to jump in and correct me in these introductory notes or add to my understanding of what this is. First of all, cancer, as we all know, is much more than a clinical diagnosis and a treatment plan. It has an effect on individuals and families, and that part of the cancer experience isn't always addressed at the doctor's office. I know I went through it with my mother, who was diagnosed with pancreatic cancer and lived for only a year after her diagnosis. Patients get sad when they've gotten this diagnosis, really depressed about it, or upset about the changes that are coming. They get anxious about the prognosis. They worry about how their family is being affected, their friends, their coworkers. There could be financial problems, difficulty with transportation, household chores and bill paying that isn't getting done, child care, and in this day and age, elderly parent care that needs to be addressed. Many concerns and many reasons that patients need emotional support more than medicine. Some would have us believe that it's not the job or the role and responsibility of the oncologist to take this on. That's not what I was trained to do. That's social workers or somebody else, not me. There are others who believe if you don't address these very personal, emotion-filled problems, the medical treatment isn't going to work. or it's not going to be as successful as it could be. So that's where you sit. As I understand it, you believe that these psychosocial issues must be addressed. So far, so good. Do I have it right?
Yep.
I'm understanding it correctly.
Very nice summary.
All right. Now, that's why some members of this group, including my panel members in front of me today, worked very hard for a very long time to get buy-in from this major physicians group, the American College of Surgeons, who have agreed to screen cancer patients to assess their psychosocial well-being and then refer them to services or treatment if that's necessary. And the American College of Surgeons Committee on Cancer thought it was an important enough issue that they made participation in distress screening a condition of APOS accreditation. So far, so good.
In 2015.
In 2015, that's my very next phrase, every cancer practice in the country that is APOS accredited must demonstrate that they screen patients for distress at least once during treatment. And those patients who are found to be in psychosocial distress will be referred to treatment or helpful community resources, right? And the medical practice will have to follow up with that patient or those patients to make sure that they got the help that they needed. And all of this has to be documented, records have to be kept, and as I understand it, Dr. Fleishman, there's going to be a team almost of field workers who will go out and check periodically to make sure that the standards are being met. Is that right?
Well, to be certified by the American College of Surgeons Commission on Cancer, there's an in-person and document review every 3 years. This will be part of the routine document review with many, and visit with many other factors that are also checked.
All right, got it. Now, the biggest question that I had when I heard about this was, how were you ever able to get this adopted? How long did it take? Who would like to start? Dr. Fleishman?
I'll start. When we were taught as fellows to make presentations, we were taught to have 3 things that your audience needs to remember. So here are the 3 things. Credit Jimmy, blame me, and it's a good thing. So remember in the old days we had 5 1/4-inch floppy disks and then 3 1/2-inch floppy disks and then zip drives, and I went through all my old documents that went back to 5 1/4-inch floppy disks, and I found some information that I think will help sort of center the chronology of all this. But my records go back to spring of 1997 when I got this really formal letter in the U.S. postal mail, before we had email, from Jimmy, inviting me to a dinner meeting at Memorial. I think it was a cold March night, and we were about to discuss screening patients. And there were a number of meetings, all of which I can't document, some at Memorial, some at the Center for the Advancement of Health in Washington, D.C. Jesse Grumman lovingly donated both space and time to help us squire this project through. I have lots of notes from all these meetings. I also have lists of people who came, since I seem to be the one who sent out the invitations because I was president then, of the progenitor of APOS. It was Jimmy, John Levinson, Diane Blum, Matt Lascalzo, Ruth McCorkle, George Hanzo, Bob Twillman, Jesse Grumman, Alan Valentine, Paul Jacobson, Dean Wolcott, and Donna. Please excuse me if I've forgotten somebody, but that's the list that I have. And we had a patient representative who had melanoma, whose name I don't have. And we met and tried to figure out how we can actually case find in a logical and reasonably easy way, and met a number of times, and at some point, Jimmy had produced a thermometer. It was a very simple graphic that a kindergartner could have done, but it served the purpose because it was so simple. And it had no distress. I don't remember what the original top said, a lot of distress or significant distress or severe distress. And she, really came up with a novel idea. Pain's doing it, let's do it too. But as we met and as we tried to extract the P words, so psychiatric was not great, psychological was no good, we even knew that palliative was no good because everybody's afraid of the P words, we then came up with the D word and then set out to define some of these parameters. Again, these are my notes. This is the best I can do, but by 1997, coming home from a CALGB meeting, I was lucky enough to be in a cab with Jim Holland and Jimmy Holland were at the airport, and our plane was delayed, and was sitting on a bench at the airport, and I got a call to renew a nebulizer for a patient, and I could never remember how much ipratropium to give, and I pulled out my Yakima guide to hospice care from Yakima, Washington, which was really small and fit in my bag since we didn't have Google in those days. And I looked at the doses, and then we were talking about the dimensions of distress, and I started looking through the index and to figure out what in this little book applied to people across the board from the time of diagnosis through end of life or survivorship. And by the end of that flight, I had picked out all the different things, and then the committee went on to vet that as a problem list. And we met a number of times. We wanted to get it down to a page. We wanted it to be clear. We wanted it to be easy. And the interdisciplinary group, in my recollection, was extremely collegial, and we were all focused on the same issue. And it was really a joy project to work on. We met all over the place, had tons of conference calls. I think we even faxed things by then because we finally had a fax machine. It was, again, way before email. And at some point when we met at the Center for the Advancement of Health, Jessie Grumman actually sat with us for a whole day, and again, wound up with 3 things at the end of the day. And she was very clear that in order to get this done, we need something called science push, a deliverable, and market pull. And science push was to have the evidence that screening is reliable and valid and that it works. The deliverable was some instrument or some system that we were going to propose, and the market pull would come from 2 places. Would come from a groundswell of patient advocacy groups who really thought that this is really a good thing to do and should be intuitive and should be part of routine care. And Jimmy mentioned going to joint commission with it. And
let me ask you this. At this point, how long have you been working together, but you haven't gone to the physicians group?
It's about
yet?
3 years.
It took 3 years.
About 3 years.
Before you went to the group. All right. And how did you pick that it was going to be that particular physicians group and not, family physicians? Or
there are two types of accreditations in the United States for cancer centers. The sort of the big guys are the National Cancer Institute Comprehensive Cancer Centers. These are the Memorials and the Dana-Farbers and the MD Anderson.
Moffitt Cancer Center.
Moffitt. I don't want to leave anybody out. But most of the patients in the United States, more than 75% of patients, including those hospitals, are also treated at smaller cancer centers that are accredited, that are generally part of Med-Surg General Hospital, not standalone hospitals. And the American College of Surgeons Commission on Cancer are the ones who accredit those. All of the NCI-designated hospitals, I believe all of them, also have an American College of Surgeons Commission on Cancer designation, but it's sort of pro forma because the other accreditation is so rigorous that it's not the same as a community hospital would go through. So it's kind of like when you work at an NCI hospital, you don't even realize that you're Commission on Cancer accredited because it's so different.
Right.
So I had said, who we need to really get involved? We need to get involved the Commission on Cancer. And we agreed that we would go to those 2 groups. And I have, in my notes, 2 letters from August 5th of 1999, one to Joint Commission and one to a woman named Joanne Sylvester who worked at the American College of Surgeons, introducing this and asking for their help. Along the way, this got a push with NCCN, the National Comprehensive Cancer Network, because at that time, and again, this is what in my notes, it may be not 100% accurate, but I believe it's sort of the general trend that At that time, the larger cancer research hospitals were having trouble signing managed care contracts because they were on a different reimbursement, a non-DRG reimbursement system. And the insurance companies were hard-pressed to refer a patient to an expensive hospital with a blank check. And they were on a different payment system. So the large cancer research hospitals got together to see how they could cost out a case of, let's say, stage 2 breast cancer, or stage, or thyroid cancer, or colon cancer by stage, and then not get into, well, if we're going to cost it out, we need to define what is good care. And how do we define what is good care? Based upon evidence, based upon articles in the literature, based upon 2 experts having lunch. How are we going to decide what is good care so we can cost it out? And at that point, Jimmy and Roger Wynn agreed, and I'm not sure who approached who, I'm not sure I ever found that out, agreed that one of the factors that the National Comprehensive Cancer Network would use in this mix of what is good care would be some sort of psychosocial panel. And here we were developing the distress monitoring system.
All right, okay. Would you like to add anything? Yes, please do, Lynne.
Sure. So I had the opportunity at the APOS meeting in February of 2009 to speak with Dr. Holland about the recently published IOM report on cancer care for the whole patient, and said, Jimmy, isn't this great? This will be practice changing. And she said, no, it won't. The IOM report is wonderful, but what we really need are initiatives that have teeth behind it, meaning reimbursement and clinical mandates. Mm-hmm. So a few months later, when APOS asked me to be the representative on the Commission on Cancer, Dr. Fleishman's term was ending, and they asked me to represent APOS, I jumped at the opportunity because I saw this as an opportunity to potentially advance an accreditation standard related to psychosocial care. So the timeline for me was in June of 2009, my term began, and I was very fortunate in terms of timing, and that the standards were currently undergoing the process of being revised, which occurs about every 5 to 7 years. And so I immediately jumped on conference calls every other week, and every member organization that belongs to the Commission on Cancer was asked to submit a potential standard for consideration. So I worked with APOS, and we drafted a distress screening standard that was discussed on our conference calls from roughly July through March of 2010, and I continued to advocate for the importance of this distress screening standard. And to address your question about how did this happen, I kept citing the evidence. Stewart shared that when he advanced a distress screening standard years earlier, the Commission responded and said, you don't have an evidence base to support this. So I was able to say, we have an IOM report documenting the outcomes that result from unmet psychosocial health needs. So this is a community accomplishment in advancing the standard and having a solid evidence base. So our meetings occurred for a few months, and then teleconferences for a few months in reviewing new standard drafts. And then in March of 2010, the Alliance of Quality Psychosocial Cancer Care provided a letter of support supporting the standard, and it was signed by 22 Commission on Cancer member organizations, including organizations like the American Cancer Society, Livestrong, the Cancer Support Community. So we really were able to rally tremendous support among member institutions behind the standard, which was an important component in obtaining Commission approval. And then at we meet annually in Chicago. The Commission on Cancer meets annually in Chicago every year. And in May of that year, in 2010, Dr. Edge, the chair at the time, shared that the working group, first our working group had to approve the new standard, and then the Commission had to approve the new standard, and then it had to go on to, I think, 3 or 4 other levels of approval, review and approval. So in May of 2010, it was announced that the first most important review and approval by the Commission had occurred, and that the standard was then going on for additional levels of approval. And that occurred from May of 2010 through September of 2011. And a press release was issued in September of 2011 announcing the ACO's new patient-centered standards. And I had the opportunity to ask Dr. Edge in October of last year. He was the chair at the time, and I asked him, I said, it seemed like we had these calls and activities and discussions about the distress screening standard, and then there would be silence for months. You know, what was happening, and how do you think that this went forward? This standard, this distress screening standard, which was new for a new type of standard for the commission, and he said there were really three key factors: the evidence base, and we have several key constituents who are support communities who advocate for patient-centered care. So that was a very an important consideration as well. And he said, you know, we recognize that this was a growing trend. We see NCCN, IOM, ASCII COPE initiative, and so we really wanted to be a part of patient-centered care. And they also observed that other work groups were initiating patient-centered standards, including providing patients with cancer survivorship care plans and patient navigation programs.
Did you get a sense that it took a lot of arm twisting among the physician membership?
Yes. Yeah, it did. And I was relentless in you know, continuing to make the point on our work group calls, call after call, about you know, addressing the concerns. And initially the conversations were about, you know, well, why should we be doing this? Why should this be part of cancer care? And so I would highlight key findings from the IOM report. Patients, we can't optimize cancer treatment outcomes if patients can't afford care, if they can't afford to get to the medical center, if their anxiety interferes with their ability to communicate and make good decisions in their best interest. And so the conversation then really shifted. Again, you know, I agree with giving Dr. Holland credit. The IOM report was critical in then shifting the tone of the conversations from how to, or from why to how. And then the concerns really became more practical in nature. There was an assumption early on that if we're going to advance a distress screening standard, this means that every practice is going to have to hire a mental health professional, and practices can't afford to do that. And I said, no, not at all. We have wonderful organizations like APOS, AOSW, and other organizations that are ready and waiting to help with implementing programs. And by the way, you probably already have a lot of these people at your institutions. You just need to find them, your psychosocial teams. And then also the cancer support community really was critical at that point as well, in working with commission members to show them how we could implement in settings from very small community practices to large academic centers, programs that are feasible to implement at little cost and that wouldn't require hiring new staff, but rather would just involve implementing connections with existing networks.
All right. And let me just mention, we are trying to save a little bit of time at the end of this presentation so that you can ask questions. So if you do have questions along the way, please jot them down, and we'll call for questions when there are about 15 minutes left to this session. We're wondering if you saw any differences in the reactions to this program in, say, RNs versus nurse practitioners versus physicians. And I'm curious to know if there was a generational split between the younger, newer healthcare people coming in versus those who had been in for a very long time and had their systems and their offices already arranged and set up. Would you be able to address that? Was there a difference in the reception?
That's a wonderful question, and I haven't thought about it in that way. I think that there, in terms of type of provider, physicians versus nurses, I think nurses really appreciated that distress screening programs can help them to make their clinical encounters more efficient, whereas physicians had concerns about, you know, well, if you ask patients, you'll make them upset, or, you know, if you ask patients, then you'll significantly extend the length of my visits with them.
That's what I would expect.
Right.
Where the objection would be. Go ahead, Stewart.
When we originally thought about this, we thought about a program that would be helpful in a private small office all the way to a cancer research hospital. And one of the things that was very clear to our interdisciplinary group at the very beginning is there are only two people that are common to each of those settings. The subspecialist oncologist, be it a surgical, medical, radiation oncologist, and an oncology nurse. And one of the things I find when I'm going and doing surveys is that I always ask, do you ever see a patient and never say, how are you? And it's often not only the oncologist, but it is often, or pretty, I would say 100% of the time, the oncology nurse.
Well, that opens a can of worms, doesn't it?
It
If you
certainly
ask,
does.
how are you doing? That could be a problem. I understand that the physicians were worried that it would take extra time, extra people, extra money. How are we ever going to bill for this? Do they bill for it? Is that addressed? Is that a factor?
Billing for distress screening, I don't think that there is a mechanism for that for billing, and it's a touchy issue.
Is it? I imagine so. It'll just be added to their daily tasks.
Right. So, I'm no expert in billing. I believe that if it's an extended encounter and it's extended by discussing psychosocial concerns or by involving a social worker, for example, at our own institution in radiation oncology, our social worker is often a key part of the medical visit, then that it changes the level of billing in terms of the extent of service that's
Sure.
provided. But we've had, just in a meeting yesterday here at this conference, we had a long dialogue about billing and who's billing and who is providing services in terms of psychosocial care delivery, who's providing care supported by philanthropy, and it's a very challenging issue.
Did you want to
Yeah,
add, Stewart?
because before the Affordable Care Act, we were living in two billing worlds. Because of Medicare, we were living in the inpatient billing world and the outpatient billing world. The inpatient billing world, to get Medicare reimbursement for a stay, there has to be a social worker involved in the care, or a case manager, or somebody who's either visiting the chart, more likely, or visiting the patient, sometimes on the inpatient unit. That person is already built in. In the ambulatory arena, it's totally different. There are sometimes people, sometimes there aren't. Larger hospitals, larger cancer centers do have a social worker, a nutritionist, a physical therapist, in variable combinations due to billing issues. But we didn't specify whether this was outpatient only or inpatient only. We wanted to leave that to the folks who are doing the work to make it theirs and to make it adaptable to their environment.
Has it been tested anywhere? Has anyone tried this in their practice yet?
Distress screening?
Yes.
There are a number of models that have been implemented that range from paper-based questionnaires that patients fill out to electronic-based questionnaires that patients fill out. I think health informatics provides a very exciting opportunity moving forward to implement distress screening in triage. Some sites have implemented clinician-administered questions. That's a fantastic question because the first randomized clinical trial, our gold standard in advancing the science is to conduct a randomized clinical trial, and the first randomized clinical trial on distress screening was not published until November of 2010, actually. It did demonstrate, Linda Carlson is the first author, and she demonstrated that patients were randomized to usual care, distress screening, or distress screening with referral, and she demonstrated that distress was significantly lower at follow-up among patients who were screened and referred for follow-up care. And this was well into the process already in advancing the standard through the Commission on Cancer. But when this RCT, the first RCT was published, I was able to say, see, I told you it works.
Go ahead.
So in 1999, since I had a vested interest in this, we instituted routine screening at the Continuum ambulatory centers, both at Beth Israel and St. Luke's Roosevelt. It took a year to get it done. It was difficult to get it done because it was a new piece of paper. So when the patients came in, our receptionist didn't quite understand that they needed to give the piece of paper to the patient. The techs who brought the patient in for an office visit who would take the blood pressure and ask about pain. They already were asking about pain, asked them about distress. We then took the piece of paper, put it on the chart, upside down HIPAA, put it on the chart upside down, and many times the physicians would actually start to look at it on the way in. And it turned out that that was the biggest selling point, because we all know what it's like to go into a room when the door is closed and you have no idea what's going on inside. You can either have a very unhappy, distressed bunch of people, because often it's a bunch of people, or you could have a rather satisfied patient who's doing really well with family who is ecstatic. So it turned out that the buy-in from the physicians that I worked with came from the idea that they could look at this piece of paper, even if they didn't read all the details, and if they saw it was a 3, they'd be able to pull up their chest, walk in and say, "Hi, Mrs. Jones, how are you doing today?" And if it was a 9, they would see what was checked, and they would tell the tech or the nurse outside, "Call the nutritionist, call the social worker. We're going to need help here." And it actually helped because it kept the flow of patients even. So a patient didn't dwell in the exam room when there were patients waiting, but the patient and the family could be moved to another room where they would see the social worker, the nutritionist, or whomever.
Right.
So it turned out that it was helpful after people saw the value in it.
Is there going to be a standard way to conduct these screenings? Or will everyone, every doctor's office get a sheet of paper that says this is what you do? Or do you have to make it up yourself?
There's not a one-size-fits-all model, and that's because every practice is different. Their clinical workflow is different. Their resources are different. Patient populations are different. And as Dr. Fleishman mentioned earlier, we intentionally wrote the standard to have flexibility, to allow sites to make their own decisions about which screening tool to use, what time to administer the screening measure at first visit, at second visit, at the end of treatment, and also how the tools should be administered. Should it be face-to-face by a clinician? Should they be questionnaires that the patient completes on their own? So the standard has some flexibility by intent to allow sites to implement what works best for their institution. I do have a little bit of a concern that institutions may do the bare minimum to meet the standard and hope that we can collaborate with programs and implementation and designing and implementing systems that do exactly what's intended, that truly improve quality of care.
And the other thing is that at the physician's office, they don't have to provide, as I understand it, the treatment or the services.
Right.
Correct.
And that's a key important factor. They're basically referring.
Right. The standard says treat or refer. It doesn't say you must do everything. Part of our sort of unwritten hope, and again, I'm speaking for the committee, I hope I'm not speaking out of turn, is that this tool a tool that will help in a quantitative and qualitative way help patients and families and staff figure out what's going on, will find the patients whose wheels don't squeak the loudest. And the teaching point I always use is your child comes home from school and you say, "What did you learn today?" And your child says, "Nothing." You walk into a room and say, "Mrs. Jones, how are you?" And the socially acceptable response is fine. And then you see a family member standing there like this.
Exactly.
Talk outside. And then, "Oh, he's paid." Blah, 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 blah. And it's,
Yes.
our belief, and I'm not sure we've ever really validated this, is that people can be a little more candid on that piece of paper or in some question mode, whether it's electronic or paper, because they're not using the socially acceptable response.
Mm-hmm. Do you think it would make a difference if it's a form that the patient fills out privately, him or herself, or if it was something that was delivered by a nurse, say, for example, asking these questions, so that you're more accountable in that way? Or
Right. So we do have some evidence that when it comes to reporting sensitive information, emotional distress, sexual behavior, drug and alcohol use, that people tend to be more open and disclose more information on paper than when compared to a face-to-face interview.
Interesting. All right. There are a couple of models that I understand the two of you have preferences for conducting this survey. The distress thermometer you mentioned a little bit about. Is that something that's still applicable today and could be used?
Again, I can't be objective about this. I think it's a really nifty tool, but the standard says a quantitative and a qualitative measure, or our NCCN guideline says a quantitative and a qualitative measure. It does not say you must use our tool. Lots of places do things in different ways, and I think people have to use what they feel is best if they can back up their choice, as long as they're meeting the goal, which is to find the people who are distressed and help them get to the right help.
Do you have a particular tool, Lynn, that you like?
That's a great question, and it really ranges from depending on how much time we have.
How much time do we have? How are we doing on time? Does anyone? I don't have a watch. Okay. All right, great.
I think at a bare minimum, the distress thermometer plus a brief measure of depression should be used. We have some research recently conducted through the radiation therapy oncology group through a large RTOG trial, and also some research that we published from Northwestern University a few years ago that demonstrates that the distress thermometer is pretty good at capturing patients who have anxiety, but it completely misses patients who have depression. It's like taking someone's temperature to find out what their weight is. The thermometer just does not work in picking up depression. So I hope that sites will consider a brief measure of depression in addition to the distress thermometer. We're fortunate at the Lurie Cancer Center at Northwestern University to have access to NIH PROMIS measures, which are state-of-the-art measurement science tools. And so our preferred approach is to administer PROMIS tools online with electronic health record integration because a medical appointment triggers an assessment that goes to the patient. Ideally, they fill the assessment out at home before they come in, and then their results automatically go into the medical record and alert the physician and nurse if there's a severe symptom or a severe distress, and alert the social workers to psychosocial concerns that the patient may be experiencing.
And in your opening remarks, Stewart, you said that you tried to avoid using those P words in naming this problem. The word distress. Now, why distress? Well, because that would be distressing to me to find out that I'm distressed. And I'm not just sad, I'm distressed.
As far as I remember from our discussions, that was the least bad word, and we actually debated quite a bit about a better word, and we even had an idea that we needed a word that was translatable into other languages.
Interesting.
So we we circled those wagons circled them many, many times, but we came back to distress because it was the least bad word that anybody could think of.
Interesting. What have you found is the effect on patients who receive this distress screening? How do they react to it?
It really varies. At Northwestern, it varies from patients who say, this was wonderful. I didn't know that my team was interested in these things. I mean, the patient-provider communication in oncology is so complicated. Patients don't want to be a complainer. They don't want to be a bad patient. Their doctor is saving their life, and they don't want to distract their team from treating their cancer. At the same time, providers assume that if the patient has a concern, the patient will bring it up, so they don't ask. And some providers may even feel that asking about distress is perhaps a bit intrusive. And if their patient had a concern, they would be able to see it, or the patient would tell them. So I think oftentimes patients will say, I really appreciated that you truly care about how I'm doing. Thank you for asking me these questions. I saw a patient earlier this week who received a form, not our institution, another hospital, who received a paper form out of the blue asking questions about suicide. And she said, why did you single me out, and why are you asking me this?
Right.
So I think there was a communication breakdown and not educating the patient on why these questions are being asked. But generally, I think patients respond positively to being asked how they're doing and being asked to report concerns. I think, though, the challenge to us now in advancing the science is in implementation. Which patients, which tools, what times should these be administered? I think some of our patients who are asked repeatedly get tired. They get assessment fatigue. They don't want to be asked every 2 weeks or every month. But we know we need to check in periodically to see how patients are doing. So sometimes they express frustration at being asked too often.
Interesting. Did you want to add
something?
Yeah,
I have 11 years experience using the tool. And at our place, I think it set a tone of we care about you, which people would comment about. We worked a lot, and with my late colleague Cindy Turkeltab, what many of you know, worked really hard to not overdo and not underdo and figure out what's a pivotal visit, which is different for a woman coming back after treatment for adjuvant breast cancer to some of our head and neck cancer patients who practically lived in our ambulatory center, though never were admitted to the hospital. And we had to find what was important for each one and when to do it. If you had a patient on chemo and radiation and you did it 2 days after the chemo, they were in bad shape, no question. But if you did it a week later, so we had to make sure that we kept in context the answers based upon where they were in their treatment, as well as how they were doing on a variety of levels. So we gave it out with a different frequency for different patients, which was a bit confusing to our clerical staff. One day I walked into the infusion room, and I'm just walking across this open room, and like many infusion rooms have, to see a patient. Suddenly I felt something, and a patient threw a piece of paper at me, balled up, and it turned out it was one of our lovely patients who was getting IV, I think it was interferon, IV for 5 days in a row. So they gave her 5 slips, and by Friday she didn't want to fill it out anymore, so she took it and she threw it at me as I came in the room. That was an important lesson, that we really need to identify what a pivotal visit is, and it's different for different people.
Yeah.
Well, my question would be then, does every patient get the questionnaire or the screening? Everybody?
That's what the standard
That's what it calls for.
Correct.
Is once enough in a patient's cancer journey?
I don't think so. I mean, I think that we have a lot
But that's as good as you have right now, is,
correct.
Is
Yes.
one intervention.
One.
Okay.
Yeah. The NCCN guidelines recommend follow-up, periodic follow-up. But, our patients have very different experiences, even patients who have the same cancer and who go through the same treatment regimens. For some breast cancer patients, for example, their time of diagnosis and treatment planning is terribly frightening and distressing, and then once treatment is underway, they feel better. For other patients, they go into survival mode, and they get through the crisis of diagnosis, surgery, chemotherapy, and then when they finish treatment, and they're no longer coming in regularly, and they no longer have
that interaction. Yes.
And then they're getting back to life as a cancer survivor, then that's when the emotional aftermath hits. So I think that we, ideally should be screening for distress periodically, particularly at times of transition from one treatment modality to another, from surgery to chemotherapy, transition to survivorship, and periodically among our survivors as well.
Mm-hmm.
Once is a good start. Before we use the thermometer, Cindy, our social work manager, was seeing patients to get transportation vouchers. Patients who had Medicaid would get their transportation paid. Some patients had car service paid for them based upon their clinical needs. And there was a paint store in the New York City area back in the 80s called Martin Paints. And then they became a home decorating store. So their commercial on radio was, "We ain't just paints." So Cindy got tired of giving out transportation vouchers and not using all of her skills, and she would always say, "I ain't just transportation."
Aww.
And this gave her the tool to get people in. Okay, here's your Metro card. Now tell me what's going on.
That's
and let's.
great.
So it set a tone, but it also allowed people to make that very last step and get beyond the P word.
Right. Oh my goodness. We have 5 minutes. Let me throw a question at you that Teresa would be asking if she was here today with you. She says in her question, it is the opinion, I've reworded it to soften it slightly because I'm not in the field and I don't want to get paper thrown at me. But it is the opinion of some who work with cancer patients that some oncologists are uncomfortable acknowledging mental health and psychosocial issues with their patients. And those who aren't uncomfortable, maybe they're just indifferent to it. My colleague who isn't here with us today, Teresa, not me, tells me that it is her experience in medical oncology clinical practice that the only treatment a medical oncology physician won't offer is Prozac. What is your observation to this? That they will treat you until you have your feet in the grave?
No, I think it's very, very
But they
variable.
won't address the mental health
I'm
issue.
sorry. I think it's very variable. It depends upon many, many factors. The individual's comfort with discomfort or distress, all the way to how they were trained, all the way to their skill level. It varies so much from person to person. I've found that amongst our colleagues, oncologists are probably some of the touchiest, feeliest docs I've ever met in my whole life in general. It's very impressive. It really is impressive. The stereotype that the public has is so different than on a personal level. To me, it's much more of a flow issue, especially now when we're asked to do so much more with so much less. When that person is in that room more than a certain number of minutes, not only does it affect your whole day, but the people who have appointments later then become angry with you because you did the right thing by spending time with patients and families. So it's not just a personal comfort level, or it is for some people, but not always. That may be an over stereotype. It may be just a practical issue as well, but it's all over the map, from extremely involved to more involved and less involved and distant, and that could be protection, could be because people just don't feel that they have the skills. It could be for a whole variety of reasons.
Well, when you're in this healthcare industry where you actually have hands-on work and interactions with patients, are you taught how to have these more sensitive conversations with patients and family members? Is there any kind of training or teaching, nurses included, physicians, anyone who has hands-on contact with patients?
Well, in good training programs, we have not only developed but carried out routine mandatory training for the fellows. You talked about a generation gap.
Yes.
And maybe medical students are really the ideal time, because by the time you finish, your habits are imprinted. But I've found, training generations of medical oncology fellows, radiation therapy residents, that they're really, really scared when they first start, because they just are afraid that they're going to mess up. They're going to put the wrong dose of adriamycin, and they're going to, get somebody really sick or kill them. And once that initial period is over and they feel a little more comfort with the mechanics, then they can sort of take in the whole gestalt and see, who is this lady? What are we doing here? And after that initial skill set reaches some level of accomplishment, we then can say, well, how are you doing? And then teach them how to respond to that. It's very tough, and again, it's very variable, because some people are really skilled and some people are less skilled, but we want to do something that everybody can do safely, and emphasize that this is triage.
Yes.
Just because you take somebody's temperature doesn't mean you treat their meningitis, right? If you ask, how are you, you're not expected to fix it. And it's a team effort. And that's the beauty of, again, can't be objective about this, working in an accredited cancer center, because you have an interdisciplinary team who is there to work with you. Different forms, different sizes, but more or less, sooner or later, and if you're accredited, there has to be someone around or close by who can help, and this is just triage.
All right. We have time for questions now. Do we have a microphone out in the field?
Yes, there's one.
Hiding behind the camera over there. Please make your way to the microphone, and we'll try to keep our answers short so that we can get to as many of these questions as possible.
Good morning.
Good morning.
My question is two-part. I'm unclear about the inpatient, outpatient. I'm an outpatient oncology social worker, and I work at a hospital that is very small and close to the inpatient, so they're constantly pulling me, even though that's not part of what I do. So is the mandate also for inpatient as well?
There's no setting for the mandate. The mandate is that the institution, during its treatment, will ask the question. We really couldn't mandate, because different size. I've gone to hospitals that have 90 beds and hospitals that have 1,900 beds. Right. So it really is based upon your setting. There are many patients who never see an inpatient unit these days during cancer. That's great, but we shouldn't deny them services because the system is set up so that they don't come into the hospital.
Right.
So anybody can do it. Each institution can set it up as they see as best.
Okay, and I think I'm hitting most of the people because they come to the outpatient side. But their concern is that they should be getting an inpatient too, and staffing, we don't have the staff. So that won't be like a check-off when you come to audit the inpatient, outpatient, if I understand correctly, as long as we're doing it. Okay.
Yep.
Second question, I work for a large hospital that has a lot of hubs in different surrounding counties that roll up to it. So I work for the Med-Onc office, and I've already implemented distress, and I'm doing that. But since we brought on a breast surgeon, a head and neck surgeon, so they've got all these outlier offices that I don't service. So do you have any suggestions on how I can offer for them to meet distress guidelines, but they don't have the support? So it's very hard with staffing issues. So any suggestions?
Sure. I mean, I think that the extent to which you can educate and train clinical oncology staff at those affiliate sites how to screen for distress, and available community resources would be a great start.
Okay.
And,
So
go ahead.
I was just going to say, so it would be, I feel so bad because there's only one of me, and I want to be running to all the clinics. And like you were saying earlier, I don't want the minimum standard. I want these patients to get what they need.
Sure.
But I'm thinking for the ones I can't reach, like even a resource list to give to the doctor.
Sure, absolutely. And we hear so often from our patients as well that just knowing that the oncology team cares about these issues and knowing that there are resources available is helpful in and of itself, is an intervention in and of itself, whether or not the patient follows through. So even implementing questions for the oncology team at remote sites to administer with referral for available resources would be a good step.
Oh, that's so comforting.
And
Thank you.
I asked Dr. Fleishman the same question yesterday about this inpatient-outpatient issue. It's very confusing, and you provided advice for institutions, which is to reach out to your surveyor in advance of the survey to talk about your program and what you're developing and to see if it's will meet standards.
Right. This is part of the reason why it's a ramp up. No one is being, it's not a standard that can count against an institution until 2015. But the answer to your question in particular is look around your institution, see who is there, and you may find that what we thought originally was correct. It's the oncology nurse. That is the common person in all these different settings, number one. And number two, if you're doing treatment for head and neck, lung, complicated cancers, those patients are going to touch surgery, medical oncology, radiation oncology. In your hub and spoke system, like the airlines, you're probably not doing all the fancy stuff at the satellites. They're being sent to the mothership, I would guess. So that's the time you can get them. It may be a little bit later than you'd like, but don't, it's always touching to me in our interdisciplinary community that we always feel badly about not doing enough when we're doing so much. So be realistic, but figure out in your system where they can be touched, and that will be much more valuable than driving all around the city with distress thermometers in your hand.
No, and I appreciate that. I appreciate the ramp up, so it's not, immediate, and that, as long as we catch them somewhere in the system, that's comforting and helpful. Thank you.
Anyone else? Yes.
Good morning. My name is Peter Brown with the Maddie Miracle Cancer Foundation. I wanted to thank Dr. Wagner and Fleischman for telling us about the journey and the story that you guys took us down to get what I think is truly remarkable in terms of accomplishment, which is adding this distress screen to the quality standard of care, but also doing so with teeth, and not just making it a nice idea and a desk piece, but rather something that gets operationalized. We've been spearheading an effort over the last 2 years, now going into its third year, to develop a psychosocial standard of care for children and their families with childhood cancer. And fortunately, we've had the great support of Dr. Jimmy Holland, and working side by side with Lori Wiener, Bob Knoll, Andrea Patnaud, Ann Kazak, Marilyn Powell, and about 3 dozen other clinicians and practitioners that really deliver psychosocial care and support to this population. So we're finalizing a draft document. We're in the process of doing so that contains standards and evidence and recommendations. So what I wanted to ask you is, number one, do you think that this distress screen is also applicable to the childhood and their family population? And number two, do you have any advice for us as we now figure out how do we take this and give it teeth and operationalize it?
That's a fantastic question, and I confirmed yesterday with the Commission on Cancer that the standard does apply to pediatric oncology practices. So there are a lot of people in this position trying to figure out best practices in pediatrics, and I myself do clinical work and research with adults, so pediatric care delivery is a bit out of my area. I think that the researcher community should identify standards. If the evidence is not available, then identify consensus standards to determine which tools are best for children, which tools are best in pediatric use. What is the age cutoff? How young should you start giving a patient directly a distress thermometer? And these are fantastic questions. I unfortunately have many questions as you do, and not many answers.
Right. I don't think we have that many answers, but we talked about this a while ago. Using faces may be a way to go. It may not be. Again, you have to think this through with the people who know best, but using some tool that a child would relate to. But off the top of my head, I would think that you'd think this through the same way you would think having a discussion about treatment. If you have a 7-year-old who needs chemotherapy, the family is going to be intimately involved in the discussion and the details. If you have a 13-year-old, you do it in a different way. If you have a 17.9-year-old, you're going to do it in a different way. Sometimes the best information is from the child, and sometimes it's going to be from the parents, and sometimes it's going to be from both. You need to think it not as a blanket policy, but as using good judgment about who's the best informant and who's, like as if you would do informed consent. Jimmy has her hand up.
Mm-hmm.
Well, first I want to be able to acknowledge Vicki and Peter Brown, who are going to be acknowledged tomorrow morning, but for the work that they've done and for bringing the second think tank here to APOS, the appropriate home for looking for standards for children and families. And I think the points that you made are excellent. It really has to be tailored to the individual child, considering developmental needs. There are a number of tools that are validated. Most are just for parents to be able to complete it, but other studies that are emerging really speaks to the importance of being able to identify the child's needs themselves. They're different than what the parent is sometimes aware of. And so we're still in the infancy. What we do need to do, though, is to be able to implement standards into the process that you have done here for adults, because what you have may be great because children are included, but there was no science behind it, there was no thought behind it, and it's really not applicable. And I think now is the time to be able to do that.
Yep.
Thank you. Let's move on to our next question quickly. We only have about 3 minutes left.
Hi, Scott Irwin, Head of Psychiatry at UC San Diego Moores Cancer Center. Thank you for the wonderful panel. I have a comment and a question. The comment, and I don't mean to take away from all the years of work that you've all done, is I like to frame things positively, so I wonder about calling it well-being screening instead of distress screening, because we're really looking for areas of well-being and areas where there's not well-being. The question is really, what do you say to the critics that say that there's going to be a whole lot of resources put into this and not, a very thin evidence base that it's actually going to find or impact distress?
Okay. I think the IOM report documents the consequences of unmet psychosocial health needs, but I agree, we do not have a robust program of outcomes research documenting that the implementation of distress screening improves outcomes. We have the RCT that I mentioned earlier and a few studies. We definitely need more research, and we need research that takes into account system-level factors, provider-level factors, and patient-level factors in developing optimal screening programs.
Let's take our last question in the red dress. Thank you.
Thank you so much for this fantastic panel. Distress screening has certainly had tremendous impact in our pond, tremendous ripples, a lot of conversations about it. I'm curious what you've seen outside of our pond and the larger implications this might have. Are there conversations with JCO, for example, or other diseases, or are you finding that this disruptive influence is going to have larger influences to healthcare in general?
I'm embarrassed to say I don't know what's happened to Joint Commission. Maybe somebody else does. I do know that part of the reason why this took so long at the American College of Surgeons is cancer isn't their only disease. They do trauma, they do breast, and there's been a parallel process in the other in the other disease entity areas. I've seen people in dialysis centers speak about asking people, how are you, in a similar way. So I think it's catching on, but it's pretty slow.
Thank you all very much for your questions and your kind attention. And my panel members, thank you.
I do, yeah. Thank you. I wanted to thank the program committee for the opportunity to speak today, and I also wanted to share my profound gratitude to the APOS Board of Directors for this opportunity. I know that I was asked because I'm cheap. I live in Chicago, so I don't have to support travel to attend the Commission on Cancer meetings, and that's why I was, one of the reasons why I was asked. But it truly has been an honor to represent this wonderful organization on the Commission on Cancer, and I just want to again emphasize this is a community accomplishment. Is a shout out to the Olympics. I just happen to be the person who's holding the baton at the time, but this really represents an accomplishment for our field.
Great. Thank you. Thank you both.
Thank you, Irene. Thank you, Stewart. Thank you, Lynn. I appreciate it. Irene, I really appreciate it.
My pleasure. I'm so glad I
Last
could
minute.
come. I loved it.
Thank you. Thank you all. We'll see you at the next plenary.